Pro Vice Chancellor Dr. V.K. Kapoor sir, Principal and Controller Dr. Lakhotia sir, Director and Professor Dr. Sitaraman sir, respected senior faculty members, colleagues, and dear residents. It's my honor today to stand before you to present a record of the departmental activities that have taken place in the year gone by on the eve of our departmental CCR. So, this is the brief overview according to which I shall be presenting my record of departmental activities in the past year. Our vision and mission is in sync with the vision and mission of our esteemed institution. Our department was established in the year 2000 and which is dedicated to holistic pediatric care and teaching. We have 4 professors, 3 associates, 9 assistant professors, 2 senior residents and 31 junior residents. We have added 4 to the tally of 9 residents that we take every year in the last session. So we today have 13 residents every year. Our undergraduate teaching program started in 2004-05 and our post-graduation commenced in the year 2009. Since then, we have trained 67 postgraduates and another 9 are lined up to appear in their exams next month. This is a record of our departmental publications. We have more than 70 publications in renowned national and international journals in the last 5 years. It's my pleasure to inform all of you that 2 of my assistant professors, Dr. Tripta Goyal and Dr. Nikita Pal, they did their postgraduate diploma in developmental neurology from Kerala University, Thiruvananthapuram through online distant learning program. Myself, I also completed IAP NRC basic pulmonology course to help and diagnose my patients in a better way. At the Department of Pediatrics, our faculty believes in training at skill labs. All the faculty members have been actively involved in providing training in BLS as well as NRP courses on a regular basis. Our pediatric super specialties, especially pediatric critical care and pediatric nephrology, are now designated as separated departments and they are awaiting NMC recognition in the times ahead. We wish them luck. In the last year, we had developed our Child Development and Behavioral Research Center, which will be sooner or later coming up in our MG Hospital campus. The branch is now being currently run in full capacity at MG Children Hospital at Chetak Marg near Jekyll Hospital. Pediatric endocrinology has come up in a big way. We have Dr. Aarti Yadav, who is the moderator of our session today, and she is currently she is our pediatric endocrinologist and looking after pediatric endocrinology in a very nice way. The routine services like thalassemia and pediatric bone marrow transplant, pediatric gastroenterology and hepatology, and pediatric neurology are also going great guns. At the Child Development and Behavioral Research Center, we have a dedicated team who is following a structured high-risk newborn follow-up program and providing multidisciplinary services under one roof, whether it be physiotherapy, occupational therapy, speech therapy, psychology, and special education. Our principle is to provide the right treatment, the right therapy at the right time, and in a very short duration, we have achieved a good number of consultations over there. It is headed by Professor Dr. Sitaraman sir and Dr. Shikha, who has joined quite recently. Pediatric endocrinology, I already stated, is seen by Dr. Aarti Yadav, and she has seen more than 400 children and is looking after pediatric endocrine services and providing specialized tests. Thalassemia and pediatric bone marrow transplant has achieved 250 bone marrow transplants till date, and it's the only center in Rajasthan to provide hands-on training in bone marrow transplantation. Pediatric gastro and pediatric gastro and hepatology, Dr. Gaurav Agrawal has done more than 350 procedures in last 3 years, and he is doing all specialized investigations. At pediatric neurology, Dr. Ajay Goenka has streamlined the process of epilepsy surgery. The average waiting time is from the first OPD visit to epilepsy surgery is just 30 days as compared to 3 to 6 months as in the Western world. At MGCH, we have served over 10,000 children, and we have state-of-the-art NICU and PICU to help us in our services. And most importantly, now pediatric subspecialty services are available as OPD services over there as well. Owing to these, our OPD and IPD are now they are achieving new heights, and we expect to cross the 30,000 mark in the coming year. In the year gone by, we had Indian Society of Pediatric Nephrology Conference organized by by Professor Yashu Saini, in which more than 350 delegates participated, 28 papers and 98 posters were presented, and it was graced by stalwarts like Dr. Arvind Bagga and Lieutenant General Dr. Madhuri Kanitkar. World Autism Awareness Day was celebrated on 2nd April 2026. We had awareness sessions for medical personnel regarding autism in children, as well as general lay public was also made aware in the college lobby. Children from Dristy Foundation enthralled us with their performance, and we facilitated them for their efforts. World Thalassemia Day was celebrated on 8th May 2026, and Thalcon subsequently was organized in May 2026 to raise awareness regarding thalassemia. Our department has been quite proactive in organizing school health camps and outreach camps. World Breastfeeding Week has celebrated every year, and this year also we also celebrated from 1st to 7th August, in which we raised awareness about breastfeeding in parents in newly delivered mothers in the postnatal ward, as well as quizzes were also organized among UG and PG students. IAP Jaipur felicited several of our faculties on Doctor's Day. Professor Dr. Sitaraman received his Lifetime Achievement Award for his excellent pediatric services all through, and Professor Dr. Yashu Saini also received his Excellence in Pediatrics Award, and so did Dr. Roop Sharma. Dr. Pawan Kumar and Dr. Aarti Yadav were felicitated with the Star Pediatrician Award. Jaipur Medical Association also felicitated us. Dr. Priya Marwa received the Excellence in Pediatrics in Bone Marrow Transplant Services, and I was also felicitated at the same time. Our future plans are, of course, we want to consolidate our departmental services under one roof. With the blessings of the management, we hope that by this year end, we will be able to do so. We need to improve upon our subspecialty services. I have my hearts out for an asthma clinic under my guidance, a rheumatology clinic, and adolescent health services. I want to expand in my department. We want to have fellowship programs in thalassemia and bone marrow transplant, pediatric gastroenterology, and pediatric neurology. I would like to inform all of you that the following faculty members joined us in our department and have strengthened and empowered us in managing our services. Professor Dr. Sitaraman sir has joined us as director and professor. Dr. Rambabu sir, Sharma sir has joined us as professor. Both have had a rich more than 35 years of experience in SMS Medical College and are with us to empower our services. Dr. Surendra Bina joined us as Associate Professor, Dr. Aarti Yadav as Pediatric Endocrinologist and Assistant Professor, Dr. Shikha Garg as Developmental and Behavioral Pediatrician and Assistant Professor, Dr. Nikita Yadav and Dr. Tanu Jhajaria are the young faculty members who have joined our department. With the blessings of the management, we intend to work like a team. I hope in the times to come, we'll be blessed to perform our services to our kids and society at large. Thank you for your kind attention. May I now invite Dr. Bhoomika to present the departmental CCR.
Thank you, sir. Good morning, respected dignitaries, faculty, seniors, and my dear colleagues. I am Dr. Bhoomika Agrawal, second year PG resident from Department of Paediatrics. Today we will be presenting a case of 12-year-old girl with recurrent seizures. This is a case of Miss M, 12-year-old female child studying in 7th standard, resident of Jaipur, informant to his father who is reliable, and she presented to us in February 2025. Patient had chief complaints of recurrent episodes of abnormal body movements for last 6 years, generalized weakness and decreased physical activity, darkening of skin and tongue, poor appetite, and not gaining weight for last 5 years. Patient had history of abnormal body movements which started 6 years ago, characterized by tonic posturing of all 4 limbs with uprolling of eyeball and followed by loss of consciousness. It was associated with vomiting which was non-bilious, non-projectile, non-bloodstained, contained undigested food particles. Frequency of episodes were 1 to 2 episodes per year. It aggravated on prolonged fasting. There was no history of fever, tongue bite, frothing or any involuntary passage of urinal stool. Following each episode, she was hospitalized and she used to regain consciousness within 20 to 30 minutes after receiving of IV fluids. Patient also had generalized weakness and decreased physical activity. Parents noticed that she had become less active and decreased outdoor activity, frequent school absenteeism leading to decline in her scholastic performance. During the same period, there was a noticeable behavioral change noticed. She became less talkative, reduced interest in playing with friends and interacted less with family members. She had not attended school for last 1 year due to her illness. They observed gradual darkening of skin which was first noticed over gums and lips and gradually progressed to tongue, hands, feet and whole body. It was not associated with any itching or photosensitivity. Over the last 5 years, parents noticed a gradual decrease in her food intake. Earlier, she used to eat around 2 chapatis. Now, her appetite was reduced to around half chapati. This was associated with poor weight gain. She gained only 12 kgs in last 6 years and was expected to gain around 20 kgs in last 6 years. Coming to the negative history, there was no history of fever or any joint pain, no history of headache or any head injury, blurring vision, photophobia or limb weakness, recurrent pain, abdomen or chronic constipation, no history of heat intolerance or excessive sweating. The child was first born to a non-consanguineous parents with no family history of similar illness, with a younger sibling who is 7-year-old healthy and alive. Antenatal, natal and postnatal histories were uneventful with a birth weight of 3 kgs and a smooth perinatal transition. Child's developmental history revealed that she had attained age-appropriate developmental milestones and had normal scholastic performance in the initial years of schooling. But currently, due to her illness, she had a decline in her scholastic performance and frequent school absenteeism. The child is partially immunized till 6 weeks of age and a BCG scar was present. Coming to the HEADS assessment, I will be elaborating the acronym in a minute. It is a psychosocial screening tool recommended for adolescents to identify their social, emotional, behavioral and environmental issues that may influence their health. Since our patient was a 12-year-old adolescent girl, we had performed this assessment and to look for contributing psychosocial factors. In this child, it revealed a frequent school absenteeism, reduced outdoor activity and poor peer interaction. She had low self-esteem due to the poor weight gain and hyperpigmentation. There were no concerns regarding substance abuse, child abuse or family support remained good and there were no signs of depression. Coming to the diet history, it was taken on the day of presentation. Assessment revealed that the child was on a home-based mixed diet. However, the daily intake was inadequate with calorie and protein deficit of 45% and 40% respectively. Child belonged to a lower middle class family. Child had first episodes of generalized seizure. Initial evaluation including routine blood investigations and EEG and MRI were performed which were normal. The child was started on an anti-epileptic levetiracetam. From 2019 to 2023, levetiracetam was stopped by parents after 4 months and they tried some complementary and alternative medicines, but recurrent generalized tonic seizures continued. In July 2023, they obtained a pediatric neurologist consultation and a repeat EEG and MRI were done to reassess and it was treated as unprovoked epilepsy since the reports were normal. The child was restarted on levetiracetam and additional anti-epileptics like clobazam and oxcarbamazepine were added. In March 2024, due to her behavioral concerns like poor scholastic performance, the child was referred for a psychology evaluation which revealed a below average IQ, and she was advised for special education and behavioral modification. On re-evaluation, one episode of hypoglycemia was documented with RBS of 26 at the time of seizure. MRI brain was advised for reassessment of the epilepsy, which was normal, and same anti-epileptics were continued. In 2025, patient was referred to us for further evaluation and management. So to summarize, there was a 12-year-old female child having recurrent tonic seizures for last 6 years, which persisted despite multiple anti-epileptic drugs. It was associated with progressive hyperpigmentation, easy fatigability, poor activity, poor weight gain, and decline in her scholastic performance, with one episode of documented hypoglycemia during the seizure. Before proceeding further, based on the clinical evaluation, I would like to ask the audience about any possibility that you all could think we could consider here. Yeah, we could consider that. Okay, so at this stage, based on the history of recurrent seizures with poor weight gain and hyperpigmentation, we considered a broad differential diagnosis like CNS causes, including neurocysticercosis, neurocutaneous syndrome, neurodegenerative disorders, psychogenic epilepsy. Nutritional causes like vitamin B12 deficiency and hypocalcemia were considered. Endocrine causes like primary adrenal insufficiency, thyroid disorders, or hyperinsulinemia were considered. Inborn errors of metabolism like fatty acid oxidation disorder, glycogen storage disease, and ketogenesis defects were also considered. And last but not the least, autoimmune causes like systemic lupus erythematosus was considered. Coming to the general examination, it was done in a well-lit room. The patient was awake and oriented, sitting comfortably on the chair, and all the vital parameters were within normal limits. This is the anthropometric assessment. These are the IAP growth charts which are used to assess the patient's height, age and BMI. The blue dot on the graph represent the value for age and height, and these are the reference centile curves. The lowest curve represents 3rd centile and the above curve represents 97th centile. Anything below the 3rd centile and above 97th centile is considered abnormal. The child's weight lies at 3rd centile. Height is 151, lying between 50th to 75th centile, and her BMI was 11.8, which lies below 3rd centile. Overall, the child had preserved height with reduced weight and markedly low BMI. The head-to-toe examination was essentially normal, except for the oral cavity had hyperpigmentation, and it also involved palms, soles and tongue. The general examination of the child had mild pallor. The photographs highlight the characteristic hyperpigmentation noted on examination. Rest of the general examination was normal with no significant additional findings. As the patient was a 12-year-old girl, sexual maturity rating was done to evaluate her pubertal status after obtaining consent. The child was in Tanner stage 2 with bilateral breast budding, Tanner stage 2 pubic hair and absent axillary hair with no history of menarche. Considering the history of recurrent seizure, a detailed nervous system examination was performed and the child was conscious and alert and well oriented to time, place and person. Higher mental function, cranial nerve and motor examination all were within normal limits. Sensory examination, cerebellar examination and meningeal signs revealed no abnormality. Other systemic examination like cardiovascular, respiratory and per abdomen examination were all within normal limits. With this, now I would like to invite my colleague Dr. Chinmay to take us further on this case.
Thank you, Dr. Bhoomika, for taking us through the history. Good morning, respected dignitaries, teachers, and my dear colleagues. I am Dr. Chinmay Kaushik, and I will be taking the case forward. For a quick recap, we have a 12-year-old female having recurrent episodes of generalized seizures, decreased physical activity, and poor weight gain. On examination, she had mild pallor, hyperpigmentation on tongue, knuckles, and palms, and normal neurological examination. Now coming to the investigations, the CBC and peripheral blood revealed Peripheral blood film revealed microcytic hypochromic anemia with thrombocytosis. Liver function test and blood gases were essentially normal. The renal function test and total serum calcium were within normal limits. Vitamin D and vitamin B12 levels were adequate. TTT IgA serology was negative. Serum ammonia and lactates were also within normal limits. In neurological investigations, the initial two EEGs demonstrated diffused background slowing, likely because they were performed during the postictal phase of the seizure. The most recent EEG, however, was obtained in awake state, and that came to be normal. The MRI brain done on September 2019 revealed a developmental venous anomaly. This is an incidental finding and is considered a normal anatomical variant for this age. A repeat MRI brain was performed at our institution, as the previous MRI was done 6 years back and the patient was having episodes of seizures right now also. To help us better understand the MRI brain findings, I would now like to invite Dr. Devansh from the Department of Radiology.
So can I ask you a question here? So seizures, hyperpigmentation, anorexia, weight loss. Seizures, 3 drugs for the seizures. The other 3 symptoms, hyperpigmentation, anorexia, weight loss, slowness, dullness, can these be attributed to the side effects of the 3 anti-epileptics? Or are they part of the primary syndrome?
Sir, they can be, but in here they are attributed to the primary cause initially.
So why not due to side effects of the drugs? Your patient, you've seen the patient, so
Knuckles.
So the hyperpigmentation doesn't happen in drugs.
Hemochromatosis also.
Yes, sir. Hemochromatosis is a possibility. Sir, bronze like.
So what we are having here is basically an iron deficient state, sir. So it's not a situation of iron deposition. So we will be coming up with the presentation further.
Thank you, Dr. Chinmay, for inviting me. Good morning, respected dignitaries, faculty members, seniors, and my colleagues. I am Dr. Devansh Aggarwal, first-year resident from Department of Radiodiagnosis. Patient was further referred to our department where MRI brain was performed. I am here to explain the radiological findings of the patient. This is the MRI brain epilepsy protocol showing representative cuts of axial T1 weighted and coronal T2 images of the patient. There is no obvious focal interaxial lesion, no evidence of grey matter heterotropia or obvious focal cortical dysplasia. The hippocampus is normal in signal intensity and volume. No abnormal white matter hyperintensities were seen. This rules out neurodegenerative disorders like leukodystrophies. Third image is the axial susceptibility weighted image of the patient showing a bunch of vessels in left frontal lobe converging in a collector vein, which ultimately drains into superior sagittal sinus as marked by the red arrows. This is likely suggestive of developmental venous anomaly or venous angioma. No obvious associated edema or surrounding hemorrhage is seen. This finding is unrelated to patient's clinical concern and is likely an incidental finding. Overall, MRI brain was considered unremarkable and no obvious epileptic focus was revealed. Now, I would like to invite Dr. Chinmay to carry forward the case.
Thank you, Dr. Devansh. Since recurrent seizures were the predominant presenting complaint, our initial consideration was a primary neurological disorder. However, the neurological examination, MRI brain, and all the EEGs were normal. Therefore, the primary CNS disorder became less likely. Serum vitamin B12 was normal, making clinical significant deficiency unlikely. Hypercalcemia is a common and reversible cause of childhood seizures, but since serum calcium was normal, this possibility was also excluded. Thus, after excluding neurological and nutritional causes, we were left with the following possibilities. Hence, we went ahead with further evaluation. The further evaluation revealed normal TMS, GCMS and negative ANA by IFA, and the endocrine investigations revealed normal thyroid function with markedly elevated ACTH, low serum cortisol with normal mineralocorticoid levels, and this pattern is classic for primary adrenal insufficiency. To summarize our findings, we have a 12-year-old girl who presented with us to us with recurrent generalized tonic seizures associated with lethargy, poor weight gain, poor scholastic performance. On examination, she had mild pallor, hyperpigmentation and normal nervous system examination with normal EEG and MRI. Our endocrine evaluation revealed markedly elevated ACTH levels, low serum cortisol levels with normal mineralocorticoid levels, and therefore integrating these findings, our working diagnosis at this stage was primary adrenal insufficiency. Now we move on to the approach to the adrenal insufficiency. Our case had low basal cortisol level, high ACTH level, hence primary adrenal insufficiency has been established, and the next step is to use the patient's medical history to narrow down the etiology. In children, one of the important causes to consider is congenital adrenal hyperplasia. The presence of visualization, genital ambiguity, clitoromegaly can point towards the same, but in our index case, none of these were present, hence CAH was ruled out. Another important diagnosis is X-linked adrenoleukodystrophy. This should be considered in a male child presenting especially accompanied by neurological symptoms such as behavioral changes, learning difficulties, seizures, but since our case is a female, hence this possibility is also ruled out. The next possibility are adrenal hemorrhage and infiltrate. Although the initial screening investigation, that is USG adrenal, was unremarkable, hence this possibility was also ruled out. And autoimmune polyglandular syndrome is one of the common causes of primary adrenal insufficiency. When autoimmune adrenalitis is suspected, we should look for the associated features such as mucocutaneous candidiasis, hypokalemia and thyroid dysfunction, but since these were also not present in our case, these were also ruled out. At this stage, we encountered a diagnostic roadblock. As the diagnosis remained uncertain, we went to the basics and revisited our history. On careful re-evaluation, we uncovered two seemingly subtle but crucial findings, that were the child had absence of tears since infancy and difficulty in swallowing in last 3 years. For objective documentation on this, we went ahead with a detailed ophthalmological consultation, for which I would now like to invite my colleague Dr. Resham from the Department of Ophthalmology to shed some light upon the case further.
To summarize, a 12-year-old girl was referred to the Department of Ophthalmology with history of absent tears while crying since infancy. The patient had no other ocular complaints. Her visual acuity was 6/9 and 6/12. Best corrected visual acuity was 6/6 in both eyes. Her IOP was within normal limits. On slit lamp examination, her eyelid and conjunctiva were within normal limits. However, while examining the cornea, it was found to be fluorescent positive in the right eye. As we can see in this picture, diffuse superficial punctate erosions were seen in the inferior part of the cornea. Her left eye was well within normal limits. Normally, the palpable part of the lacrimal gland is visible on the upper lateral part of the eye, seen on stretching of the upper eyelid. In our patient, the palpable part was not as evident. Rest of the apparatus was within normal limits. Her anterior chamber and fundus were within normal limits. As a part of workup for dry eye, first we do a symptomatology score called as Ocular Surface Disease Index, which gives us an idea about the severity of the patient's symptoms. According to this, our patient fell under the category of mild disease. Tear meniscus height tells us about the tear volume measured using a slit lamp. When the slit lamp beam is focused in the pupillary plane, the height of the tear film is recorded from the lid margin. In our patient, it was found to be less than 0.2 mm, less than the normal limits. To measure the tear film breakup time, the surface is stained with fluorescent dye and the time is calculated upon the appearance of the first dry spot. The tear film breakup time was 6 and 7 seconds, less than the normal 10 seconds. Sherman's test was done using strip
Wortmann 41 paper, measuring 5 mm by 35 mm. This test strip is placed at the junction of the medial 2/3 and the lateral 1/3. No anesthesia is used in this test. It calculates the reflex and the basal secretion, which is the function of the lacrimal and the accessory lacrimal glands. Wetting of the Schirmer strip is recorded. Less than 5 mm indicates severe aqueous deficiency. In our patient, it was 3 mm and 2 mm respectively. So far, we have taken the patient's history using a symptom-oriented questionnaire. Tear film breakup time and tear meniscus height were found to be below the normal limit. Her ocular surface staining was positive in the right eye and the left eye was within normal limits. Schirmer's test for both eyes was less than 5 mm. All of this indicating severe aqueous deficiency, aqueous being the middle layer of the tear film. We approached the diagnosis by systematically ruling out causes of aqueous deficient dry eye. Sjogren's was unlikely based on history and inflammatory markers. Other acquired causes can be decreased lacrimal production and lacrimal obstruction. Cicatricial disorders were ruled out clinically as the ocular surface was normal. Decreased production can be due to primary and secondary causes. Infiltrative, radiation-induced and surgical causes were not supported by history or examination. The key clue was that the patient had absent tears since childhood and the palpebral lobe was not clinically evident. Hence, congenital alacrima became the most likely diagnosis, which can be due to the absence or aplasia of the gland. Therefore, for confirmation, MRI orbit was recommended and the patient was referred back to the Department of Paediatrics. The aim of management in such patients is to maintain the ocular surface integrity. We recommended lifestyle modifications to avoid any windy, dry environment, take frequent breaks while reading or screen usage, and to keep the screen below the eye level. Patient was prescribed frequent preservative-free artificial tears and lubricating gel of hydroxypropyl methylcellulose at bedtime. She was kept on a follow-up of every 3 to 6 months for corneal monitoring. Now I'd like to invite Dr. Chinmay to continue the case.
Thank you, Dr. Resham. Since alacrima was confirmed by the ophthalmology team, we proceeded with MRI of lacrimal gland, and in view of her dysphagia, a barium swallow study was performed. To help us interpreting these image findings, I would once again like to invite Dr. Devansh on the stage.
Thank you, Dr. Chinmay. Lacrimal gland on MRI orbit. Top row of images are of normal MRI orbit, which shows how the normal lacrimal gland appears on MRI. As marked by the red arrows, lacrimal gland is located anteriorly in the superolateral aspect of extracorneal space of the orbit. Bottom row of images are the MRI images of the patient showing representative cuts of coronal T1 weighted and T2 weighted images with fat suppression, showing non-visualization of bilateral lacrimal glands. This could represent agenesis or any long-standing atrophy. Patient was also referred for barium swallow in view of difficulty in swallowing. In these images, red arrow marks short segment smooth narrowing or the bird beak sign, which appears due to incomplete esophageal sphincter relaxation. We can also appreciate esophageal dilatation due to pooling of barium in the esophagus. In a young patient, these findings possibly suggest primary conditions like eclasia. Now I would like to invite Dr. Chinmay to carry forward the case.
Thank you, Dr. Devansh. Since primary adrenal insufficiency had already been established with alacrima and eclasia confirmed as associated features, the possibility of AAA syndrome was considered and we went ahead with the genetic testing. The whole exome sequencing revealed an autosomal recessive homozygous mutation on exon 1 of AAAS gene, which is pathogenic for AAA syndrome, also known as L-groove syndrome, consisting of 3 cardinal features that are adrenal insufficiency, alacrima and eclasia cardia, and all 3 were present in our case. Moving on to the management of this patient. First, for primary adrenal insufficiency, the patient was prescribed tablet hydrocortisone 5 mg thrice a day at a dose of 10 mg per meter square per day in 3 divided doses. For A-lacrima, the patient was advised methyl cellulose lubricating eye drop along with eye protection and a consultation, follow-up consultation from ophthalmic team. For achalasia, the patient is currently asymptomatic. Upper GI endoscopy and esophageal manometry are planned in follow-up. At the time of referral, the patient was on 3 anti-epileptic medications. Since seizures were due to hypoglycemia and that was well taken care of, the patient remained seizure free since last 18 months. Hence, anti-epileptic medications are being gradually tapered, and she is currently on tablet levetiracetam 250 mg twice a day. For anemia, oral iron iron folic acid tablet was prescribed, and for other preventive cares, patient catch-up vaccination was done. And finally, in view of observed poor scholastic performance, the patient was referred for a psychological assessment to evaluate the changes after the treatment and to provide appropriate support, for which I would like to invite my colleague Abhinesh from clinical psychology on the stage.
Thank you, Dr. Chinmay. Now I would like to represent Department of Clinical Psychology. Presenting complaints of the patients were below average intelligence was reported in the previous intelligence testing. As per the protocol, firstly we went for the behavioral observation. The patient was cooperative, appropriately engaged throughout the assessment. Adequate eye contact and rep was established with ease. No abnormal psychomotor activity was observed. Attention and effort was sustained across all domains. Everything was within normal limits. Upon further mental status examination, general appearance was kept appropriate to the age, contact with surrounding present, eye contact with the examiner present, dressing appropriate, facial expression abnormality was found, attitude toward examination was cooperative and attentive, motor behavior was appropriate, speech was audible, adequate, relevant and goal directed, mood and affect was euthymic, for no thought abnormality was detected, perception, no perceptual abnormality was found, attention, concentration aroused and sustained, orientation, oriented to time, place, person, passage of time, memory was recent, remote, intelligence memory intact, judgment, test, social and personal, judgment was intact. Insight was grade 5 level of insight was found in the patient. Further, in the light of the L group disorder does also come with intellectual impairment in 60% of the patient, we went for MISIC intelligence test on the patient. Mullen Intelligence Scale for Indian Children, the composite score on verbal IQ the patient scored 109.25, on performance IQ the patient scored 93.75, and the full scale IQ was 105.5. The interpretive summary would be good verbal comprehensive skills, adequate non-verbal reasoning abilities, overall intellectual functioning in the average range. Now I would like to call upon Dr. Chinmay to take the case forward.
Following the initiation of treatment, the patient showed unremarkable clinical response. She gained nearly 11 kgs of weight. Significant improvement in hyperpigmentation was seen. Her ACTH level also declined, and most importantly, she has remained seizures free during the follow-up. This slide illustrates the patient's growth trajectory with weight and height plotted against the WHO-IAP growth chart. Prior to the initiation of treatment, her weight was at 3rd centile. Following treatment, she showed gradual and sustained weight gain, and currently she is on 25th centile. And now may I invite our mentor and moderator, Dr. Aarti ma'am, to brief us about L group syndrome.
So a very good morning to respected dignitaries, seniors, colleagues and my dear students. Let me brief you all about Ollgrew syndrome. So when we talk about Ollgrew syndrome, the most important thing to remember is that all 3A of this syndrome do not arrive together in all patients. Earliest clue can be alacrimia, and parents may simply say that doctor, my child doesn't produce tears while crying. This may seem very subtle but can be the initial manifestation of a very crucial diagnosis. Achalasia often comes next, and mostly these patients are mislabeled as having reflex, recurrent vomiting and feeding difficulties before the real diagnosis becomes apparent. And then comes the most dangerous A, which is adrenal insufficiency. So these children may first present to us not with an endocrine diagnosis but with hypoglycemia, shock and seizure. And what makes Ollgrew quite challenging that there is no fixed phenotype. Even two affected children from the same family can look quite different. And from an endocrine perspective, there is one useful clue that although this is a primary adrenal insufficiency, but mineralocorticoid function is mostly intact. And Olgrus key takeaway message is that Olgrus syndrome is not just about 3A. Over the time, it can involve CNS, can result in autonomic dysfunction and amyotropic lateral sclerosis in rare cases, which constitute the 4th A and 5th A of this syndrome. So when we talk about management of Olgrus syndrome, it's not about treating one disease. It is about specific management of each aspect, and the most urgent priority is the adrenal component. And hydrocortisone is the steroid of choice in children, as this is the most physiological steroid and has least long-term side effects, specifically on growth. And the real challenge is to make sure that the family understand that steroid has to be replaced lifelong, and they understand stress dosing of hydrocortisone, sick day rule, and emergency use of hydrocortisone. Alacrimia may look least dramatic, but chronically dry eye can cause significant ocular surface damage. And simple measures like lubricant, photoprotection, and most important, regular follow-up with the ophthalmology team can prevent the serious ocular complication. Achalasia is the part which troubles the patient on daily basis in form of feeding difficulty, weight gain, and recurrent respiratory symptoms. Management is individualized, ranging from pharmacological measures in the form of nifedipine or endoscopic procedures, or most definitive approach, that is surgical, which has to be individualized depending on the severity of symptoms and availability of local expertise. So the first case of Olgrus syndrome was reported in 1978. So this is relatively a young diagnosis in medical literature, and in last 5 decades around 200 cases have been reported worldwide with the estimated prevalence of 1 in 1 million, and we have been fortunate enough to manage one such rare case. So when we narrowed down our literature search to India, we could come across 30 reported Indian patients, mostly in the form of isolated case report, with the largest case series of 8 patients published recently from KEM Mumbai. So why did we feel that this case is worth presenting today? Is that this is one of such conditions which in which right diagnosis can change a child's health trajectory completely. And although primary adrenal insufficiency as a component of Olgrus syndrome is quite uncommon, but the consequences of missing it out are not subtle. In fact, recurrent hypoglycemia seizure can easily acquire the label of epilepsy, as was done in this case. And treatment of adrenal insufficiency is quite rewarding, as hypoglycemia seizure disappears, hyperpigmentation improves, and growth improves with the hydrocortisone supplementation. So if today there is one message I would like to carry my students, is that seizure is a symptom, not a diagnosis. And this case highlighted how powerful can be a detailed and good history be. And in every case of seizure, we should actively look for reversible metabolic causes of seizure like hypoglycemia and hypocalcemia before labeling a child epilepsy. Before I conclude, let me thank management of MGUMST for providing us such incredible infrastructure and resources to manage such complex cases. And this case was truly a multidisciplinary team effort, and we are thankful to our colleagues from Department of Radio Diagnosis, Ophthalmology, Clinical Psychology who helped us in diagnosis and management of this case. We are thankful to CCR Review Committee who provide us constructive feedback for this case. And last but not the least, we are thankful for the patient and her family for putting their trust in us. And please let me allow to share the testimonial video of father from her last follow-up.
मेरी बच्ची आज 13 साल की है और जब से 7 साल की थी तो इसे थोड़ी सी परेशानी हुई, तो ये बीमारी के अंदर एक दौरे से उसको बीमारी के साथ में दौरा आया। अब मैंने इसका एक ट्रीटमेंट बड़ोदर हॉस्पिटल के अंदर लेके गया, मैं इसको वहाँ मैंने इसे दिखाया और उसके बाद में फिर को उसी के बाद में कोविड आ गया तो इसका ट्रीटमेंट नहीं चल पाया। फिर 3 साल बाद के अंदर मैं न्यूरोलॉजी के पास में घूमा, न्यूरो के सेक्टर के अंदर काफी न्यूरोलॉजिस्ट के पास में गया, तो उन्होंने मुझे डॉक्टर आरती मैम का सजेशन दिया। फिर उन्होंने मुझे एक जेनेटिक टेस्ट के लिए बोला गया। कुछ मैंने जब जेनेटिक टेस्ट कराया तो उसके अंदर AAA सिम्टम्स आए। AAA सिम्टम्स आने के बाद में मैम ने मेरा बच्ची का ट्रीटमेंट स्टार्ट किया। उसके बाद में अब लगभग 2 साल हो गए मेरे बच्ची का ट्रीटमेंट चलते हुए। तो मेरी बच्ची के अंदर जो इम्प्रूवमेंट है वो ये है कि रात की दिन है आज मेरी बच्ची का वजन लगभग डबल हो गया उस दिन के बाद। 2 साल के बाद में मेरी बच्ची को मैंने ऐसा देखा है कि मेरी बच्ची अगर किसी दूसरे को अगर वो देखे, दूसरा अगर मेरी बच्ची को देखे तो उसको वो पसंद नहीं है, इस तरीके की हो गई थी मेरी बच्ची। और आज मेरी बच्ची का कलर भी पूरा फेयर हो चुका है, पूरी ब्लैक हो गई थी ये बच्ची 2 साल पहले की में, और आज के अंदर इसमें ये ब्लैक से व्हाइट है वो, और वजन इसका 20 से 40 है। और मैं डॉक्टर आरती मैम से बहुत ज्यादा खुश हूँ क्योंकि उन्होंने मेरी बच्ची को, अब शब्द नहीं है मेरे पास के अंदर कि मैं उनके बारे में क्या करूँ। डॉक्टर आरती मैम बहुत ही अच्छी डॉक्टर है और तरीके से, मतलब उन्होंने जब भी मेरी बच्ची को देखा, मैंने मतलब अब 2 साल के अंदर मैं 10 बार गया हूँ, तो उन्होंने मेरी बच्ची को 1-1 घंटे तक तरीके से मुझसे बात करके और पूरा तरीके से समझाया है, पूरा केस को सही तरीके से समझाया कि ऐसा नहीं है कि 5 मिनट के अंदर फ्री करके भेज दिया गया मुझे।